Yeah, of course. All right, let me,
Thanks for squeezing in the lecture for us.
yeah, no
These
problem.
are, yeah, so I have Allison covering this topic because it's like one of those high yield CAQ topics. So she gets both kind of disabled and masters athlete, and they're kind of two subjects that you don't routinely think about when you're in the clinic setting, but they love to talk about on CAQs. So that's why we're talking about it today.
Yeah, the fellows last year said that they definitely got some questions from this lecture. So, um, we'll go through like the PowerPoint things, and then I have some sample board review questions at the end. And for some reason, it on these topics, it seems like there are key things that they test. Um, And so just there's not there, it seems like a ton of information, but in the whole scheme of things, this is probably pretty high yield. Like they're definitely going to ask you questions related to like master's physiology and chronic disease and exercise. And there are certain things on adaptive and disabled athletes that they'll probably ask you like one of a few things about. And so if you can know this, I think you're probably good for most of the things that you would get asked on the CAQ. And I think Suze has the PDF of the slides, so, and I think she'll record this, so when you're studying, if you need to go back through it. I did pull some of the information from the Mayo Board Review course, which tends to be pretty high yield as well, so it's hitting the high points from that and from a lot of the review books for boards and some things pertinent to clinic as well, because we see a lot of older patients who are trying to be active, and so if you can keep some of these things in the back of your mind, it's good. So we'll talk about the master's athlete with physiology of aging, effects of exercise, and then exercise and chronic disease, as well as adaptive and disabled athletes. And it's pretty hit on the high yield stuff related to those. So first starting with master's athlete, that historically was defined as anyone over 40, and they're kind of moving that down to age 35. Um, and the reason that this matters is masters athlete participation is growing. I have data here for runners in general, but think of how many people we see in clinic outside of the peds offices. Like a lot of patients that come in are like weekend warriors and active population. And as we start to age, our body starts to break down and we react differently to exercise than we did when we were 20. And people sometimes have a hard time grasping that those changes are occurring. So participation in races is increasing, but also just participation in sport in general. And in reality, when we age, there are a lot of things that play a role. And, you know, this is kind of like somewhat of a thing that you need to think about clinically, where there is the natural aging process and physiology that makes a difference. But typically, as we get older, there are also a lot of other factors that take our attention away from sport, like our work and our family time, which leads to a decreased commitment to training where we don't do as much recovery and things like that. And so when you're thinking about aging, you need more recovery, but we have less time for that. And then the same thing with training intensity and volume typically goes down just because of those lifestyle factors. And I don't know how many patients I've probably had in the last year that have had like masters athletes with bone stress injuries. And they're like, I'm not doing anything crazy. Like, I'm not doing anything differently. And then you dig a little bit more into their lifestyle, and it's like, I started a new job, or I went through this really stressful situation. And so you have to keep in mind that our body's pulling uh nutrients, and cortisol and stress is taking up a lot of the fuel that we give ourselves. So just keep those things in mind from a clinical standpoint. And not only does the natural aging process affect the cardiovascular function and our biomechanical function, but the lifestyle factors do as well. And then the training intensity and volume contribute to deconditioning and decrease biomechanical movement as those things decrease. And all of this leads to a decrease in physical activity and in performance and an increased injury risk in masters athletes. And then that kind of like cycle feedbacks back into decrease activity and performance and decrease in training volume. And so you get this kind of loop where a lot of our masters athletes that you see clinically are just kind of stuck, where it's injury after injury after injury, and they can't seem to get out of that cycle. And we really need to pay attention to some of these things. This is the J hypothesis. You may see something related to this on boards where as you increase your exercise and training volume, the health risk decreases until you hit a certain point where the benefits no longer outweigh the risks. And then you start to get this extreme exercise hypotheses, where you get an increase in your risk of not just musculoskeletal, but also cardiovascular problems, particularly AFib. And so our current guidelines are relatively conservative. That's 150 minutes of moderate or 75 minutes of vigorous activity throughout the week with 2 bouts of strength training. So, that is kind of the minimum that we want people at. And so if people are above that, that's great, but we need to be careful that they're not kind of crossing this threshold into too high of a training volume where they're actually increasing their risk of adverse effects from a health standpoint. All right, so I'm going to go through each system with the natural aging process, and a lot of this is kind of just me here, listing off things, but this is really high yield board relevant stuff. They're probably going to ask you a question from a couple of these slides. And the things I always tell the fellows is like, all of this stuff makes sense if you just take a step back and think about it. So we're going to start with cardiovascular. Like when you get older, you have a decrease in the max heart rate that you can get to. So we think about max heart rate, the easy formula is 220 minus your age. So as you get older, your max heart rate is lower. And that's roughly 10 beats per minute per decade, which is where you get, your age per year. It, adds up. So again, common things, but just think through them. As you get older, your blood vessel compliance decreases, and therefore you have an increase in blood pressure. So you think about more plaque buildup as we age, decrease in vessel compliance. Like that all makes sense. You don't need to memorize this. You need to just be able to think through things. Your resting stroke volume decreases, which therefore your maximum cardiac output decreases, and your total plasma volume decreases, which increases dehydration risk. And I think if you, just think about someone who's 80 trying to exercise, all of these things make sense. The Carbonian formula I'm putting here because I swear you're going to get a question on boards and I don't know if it's covered anywhere else. Not totally specific to aging. This is for anyone. But you might get a question that's asking you to calculate what your target heart rate is in a heart rate zone with activity. And that is calculated using the Carbonian formula, which is your max heart rate minus your resting heart rate times your percent intensity, and then that plus your resting heart rate. I probably don't know if I can say this, but I definitely had a question on my board exam that was on that formula. I don't know why they love it, and they'll disguise it in, it could be a master's athlete or even a younger athlete asking you what their heart rate zone is for a workout. Moving on to respiratory, you get increase in residual volume and decrease in vital capacity, which again makes sense. As you get older, you hold more space in your lungs that's not filling, which is the residual volume, and you have a lower vital capacity for also then what you're able to inhale and exhale over time. And some of these questions, they're still doing like which of these is best or which of these is true, and they'll give you a bunch of answers with up arrows and down arrows, and you need to be able to pick the one that works best. From a metabolic standpoint, decreased VO2 max about 9% per decade, and decreased glucose tolerance, which increases diabetic risk. Again, like if you have any exposure to athletes, which all of you do, these things make sense, right? Like this stuff isn't tricky, but sometimes people can get tripped up on the numbers. And most of the time for boards, as long as you know trends, in general, you're going to be able to figure out the best and correct answer. So from an MSK standpoint, we have bone loss, which is more rapid when we're 35 to 55 at about 1% per year, and then even higher over age 55, more common in women to have a rapid loss, especially post-menopause. Muscle mass and fiber size decrease, therefore you get a decrease in muscle strength and power. An increase in tissue stiffness, decrease in flexibility, and all of those things contribute to bone stress injuries, fractures, muscle tears, tendon tears that we see in clinic all the time. And then we'll talk later about OA, but obviously that's something that happens with aging as well. From a neurologic standpoint, you have decrease in proprioception, decreased walking speed, which leads to impaired balance and impaired fall risk, and also decreased reaction time, which again, if one of us trips, most of the time we can catch ourselves because we can react fast enough, but as you get older, that decreases and then you're more likely to get injured. And then from a body fat standpoint, that increases between ages 30 and 70, where we have increased BMI and increased risk of cardiometabolic disease. And after age 70, that actually does tend to decrease a little bit. And that is doesn't have the same obviously impact on BMI and things as when it's increasing when we're younger. So we all know this. There are many positive effects of exercise. There might be a question related to this as well, where you decrease your cardiovascular and MSK related, age-related decline. You increase insulin sensitivity, which decreases your risk of diabetes. Obviously, exercise is, treatment for that. Increase HDL, decrease LDL, manage your weight, improve mood, treat depression, improved cognition, where now there's some evidence that it can be preventative for Alzheimer's, improve physical function, helps reduce falls, improve sleep. Again, like this stuff is, I don't want to say common sense, but it's common sense for most people involved in sports med. And so regular exercise and chronic disease, you'll also probably get some questions on this there. And we know that there is an effect of exercise that decreases risk of long-term effects of cardiovascular disease, whether that's MSK, heart issues, heart failure, vascular problems, or metabolic issues like diabetes. There are several contraindications to exercise, and you will probably get a question about this. Again, most of this stuff is like, this should be common sense, right? If someone has severe atherosclerotic cardiovascular disease, you probably don't want them exercising unsupervised. If they have unstable angina, also don't want them exercising unsupervised. Severe aortic or carotid stenosis, they're having myocardial ischemia despite being on treatment, they're in an exacerbation of CHF, they have CHF with either hypotension at rest or when they're exercising, obviously uncontrolled arrhythmia or uncontrolled hypertension, cardiomyopathy, myocarditis, and contraindications potentially if they're on anticoagulation. Like these things are common sense, but it's better to see them here. There's probably going to be a question on them. I mentioned this a little bit about exercise and dementia, but the benefits on cognitive decline are becoming more and more prominent in the literature, where it's been shown to reduce the risk of dementia and increase cognitive function in ADLs, particularly in women with the improved cognitive function than men. And it's hard to say with some of those studies if it's, women who were less active and added some activity to their life and that helped better. And it's actually the first line treatment for cognitive decline, which I also pulled from a question that I had seen on board review, where what's the first thing you do when someone's cognitively declining after you've worked it up? From a hypertension standpoint, again, the contraindications they will test you on. So avoid exercise if their blood pressure is over 200 or over 110 until control on medications. And as we exercise, you do have an acute decrease in systolic and diastolic blood pressure. Acutely and chronically, there are multiple adaptations that are beneficial to controlling blood pressure. So from a coronary artery disease standpoint, when comparing cardiac rehab versus just usual care, decrease in cardiovascular mortality, decrease in hospital readmissions, decrease in cholesterol and triglycerides and SBP. This usually will start 1 week after a stent and 4 to 6 weeks after CABG. And again, those contraindications, which are on the first slide, but I promise you they're going to come up: severe coronary artery disease, unstable angina, or severe aortic or carotid stenosis. And obviously all of this makes sense. Like you don't want to put demand through the heart and the vessels when it can't be met. For CHF, exercise-based rehab improves VO2 max, SBP, ventilation, resting heart rate, but most of these things do not improve mortality, but will just improve things related to morbidity. And again, the contraindications, things that you think like common sense wise, if they have NYHA class 4 heart failure, worsening dyspnea, weight gain over, that's what, like 4 pounds, 5 pounds. And then if they have exertional ventricular arrhythmias, like probably don't want to exercise them. From a diabetes standpoint, lack of fitness is an independent risk factor for type 2 diabetes, and basically exercise improves everything related to diabetes. And, we know that. From a caution standpoint, you want to make sure that they're monitoring their blood sugar before, during and after exercise. If they have some neuropathy, make sure their footwear is cushioned. And you might get a question about not injecting insulin into the exercising body part. Maybe not in a master's athlete, but you might have a question on a marathon runner, needs to give themselves insulin before the race, like where should they inject it? And it's not into their leg. From a COPD standpoint, this I've seen, I don't know how many times in practice questions, quality of life, but not pulmonary function is improved with pulmonary rehab. So you do pulmonary rehab, you get no change in like what your lungs actually do, but it improves your quality of life. I don't know why they care about that question so much, but they do. At least in the board review questions. And there's no actual difference in aerobic versus resistance training. So for some people, again, this is mostly improving quality of life. So they're like, I know I can't walk, I can't, ride my bike, but you can do some exercises with bands. That's still better than nothing. From a peripheral vascular standpoint, we know with the disease, you get reduced tissue perfusion, slower walking, and then you're not ambulating as much. But if you can do graded exercise that's supervised, it'll improve your pain tolerance, fitness, strength, and then the distance that you can walk, where you have someone with you who's like helping you push through the pain for a while before you rest. And that just helps build collateral flow through the vessels. From a joint arthroplasty standpoint, there is no true consensus on what you can do post-arthroplasty. This is typically the paper that's cited on what's allowed and what's not recommended. And the biggest thing that they're going to test you on is you are allowed to play doubles tennis, but not singles tennis post-arthroplasty. In a practical world, this really depends on the surgeon. And there's always this joke that of like my colleagues in Utah, where they're like, every surgeon in Utah is going to let their patients ski, because if they don't let their patients ski, they're not going to have any patients post arthroplasty. Whereas in Cleveland, you might find a lot of surgeons who are like, yeah, you probably shouldn't ski post arthroplasty, because the population here is less likely to be skiing every weekend than they are in Utah. So this is surgeon dependent, but the boards are probably going to ask you about tennis for whatever reason. All right, so now there are a couple of questions just to reinforce these things. So it requires audience participation. So if you guys are sitting in there and able to take turns, if someone wants to read and answer the first question, and you're allowed to ask for help if you need it. Is anyone willing to go with the first
It's
one?
a 70-year-old patient still running half marathons. Reports that his running pace has slowed significantly, but he remains injury-free. All of the following are physiological changes seen with aging, except my least favorite question. Type of question. Okay. So muscle strength, flexibility would make sense that would go down. VO2 max, I can't remember the number, but I do remember it goes down. Heart rate of 10, I remember that going down. Residual volume. Oh, that's like lung stuff, right? So that should be worse.
Yeah. And right, because residual volume goes up and your vital capacity goes down.
Okay, so
Then
D
D.
should be the correct. Yeah.
Yeah,
Sweet.
Kevin was
Nice.
right. So this is a flashback to your primary specialty, or before that, where you have the volume of air through the lungs. And so residual volume is what's left after you exhale. And as you get older, that becomes higher, because your, again, vital capacity decreases, just like Jack said. And as you astutely went through, like the others were all true. And it's going to be, I mean, I don't want to speak obviously I don't write the test questions, but it'll be pretty rare that they're asking you like specific nuances. Like if you can know trends and kind of directions, I think you're going to be able to get what you need to know. For most of these like aging physiology questions. All right, who's next?
I'll go. According to the consensus guidelines, all the following are activities that may be allowed with prior experiences post joint replacement surgery, except.
Now I forced you to tennis, but
So
Utah.
I think double tennis is fine. So basically, you said skiing was the one that we talked about.
but people allow that. Yeah.
People do allow that. We went through that slide pretty quick.
Think about a lot of your patients. What are like most people not doing after they get a replacement?
Running.
Yeah.
I think running is my answer.
Yeah. So really high impact activities. They typically want you to avoid. Being honest, I know people that run on their replacements. I haven't seen them for long enough to know if it's failed or not, but that's typically something that across the board, most surgeons say no to. Anything that's like high impact HIIT workouts, jumping, they might give you like a volleyball, answer or something that requires a lot of jumping. And then, yeah, the doubles tennis is fine. Downhill skiing, if you have prior experience, most of the surgeons will say it's okay. But again, the nuances of being at the discretion of the surgeon. This I pulled from, a sample question, so.
Can I ask a quick question about this? Is this just because you're not as concerned about like ligamentous injury? Like, I think just logically, it strikes me as like, this is a question I'm going to miss when downhill skiing seems like significantly more impactful. Maybe it's because I'm not a very good skier, but I feel like jogging versus getting launched down a mountain seems like,
I think that's where the prior experience piece comes in.
Yeah.
And also I don't know if anyone has done a study that skiing is a problem if you crash, right? Like it's always a problem if you crash. It's going to be a problem if you crash without your replacement or with your replacement. Whereas like the wear to the replacement with repetitive high impact activity over time is probably more likely for the replacement itself to be a problem. If someone crashes when they're skiing, they're going to hurt a bunch of other things. They're not going to be mad at you for your joint replacement failing.
Makes sense. Okay.
I think that's probably where those recommendations come from. All right. Who's next?
I can do it. All right. 70-year-old female with a history of osteoporosis and moderate bilateral knee OA presents to your office. Which of the following would be the most appropriate statement regarding exercise recommendations for this patient? A, advise participation in a high impact exercise program focused on strengthening flexibility and function. B, advise participation in a multi-component program that incorporates aerobic exercise, muscle strengthening, and balance training. C, encourage bending and twisting exercises to promote flexibility, such as sit-ups, golf, and tennis. Or D, discourage exercise given the risk of fracture and or arthritis progression. Okay, so definitely not D.
Good job.
I don't think C is gonna do all. It's probably A or B. Let me just look.
He probably low impact.
Yeah, because A is high impact, so it's probably B.
Yeah,
I think.
exactly. And I really like how you went through your thought process with that, where like there are going to be questions like this on boards where it doesn't just like, it's not like a, do you know this or not quick thing where you can as long as you're like rational, get to the correct answer just by crossing things off. So that's like basic test taking skills, but it can go a long way in some of these because even though we didn't even talk about this question at all, like specifically, you were able to like rationalize through to the answer and basically what you said. I don't need to read the slides. All right, there's one more. This we haven't talked about at all, but let's see if you can reason your way through. So no pressure to whoever takes this. Like obviously there's no pressure on any of this. No, it's great now. Cody, are you able to see the screen that you want to take this one?
Yep. Sarcopenia results in which of the following changes to muscle cells? There we go. Let's see, a decrease in number of muscle cells and increased fatty infiltration. A decrease in muscle quantity and increased mitochondrial density. An increased number of muscle cells and increased fatty infiltration, or an increase in muscle quality and decreased mitochondrial density.
Just think about what the roots of the word mean, right?
I mean, I would think pineal would be a decrease. So I'm going to go ahead and rule out C and D, and then let's see which one makes more logical sense. I mean, I want to think a decrease in muscle quantity would increase mitochondrial density. So I'm going to go with fingers crossed A, Hail Mary.
Yeah, no, you're right. Decrease in number of muscle cells and increased fatty infiltration. So sarcopenia, we lose skeletal muscle mass, which happens with aging in general, and then that decreases the quantity of muscle, and that has to be basically something else replaces it, which is fat. And when you have a decrease in muscle cells, you also get a decrease in mitochondrial density. And again, if you're like thinking back to like basic science, whenever we talked about mitochondria, that's the powerhouse of the cell with like what produces the energy. And as you get older, that it makes sense that that would decrease as well. So like that is a really good example of a question that is related to master's athlete that like we didn't specifically talk about, but you can kind of like rationalize your way through. So excellent job. All right, we're back to the top of. Someone wants to take this.
Which of the following is not a known physiological change that occurs with aging? Decrease maximal heart rate, a decrease in total body water, an increase in tissue stiffness, decrease in flexibility, increased thirst mechanism. I would say an increased thirst mechanism doesn't make a ton of sense to me.
Correct. And so we had talked about all the other ones, but not about that. And the thirst mechanism actually decreases, which is what puts people at even higher risk of dehydration as they get older. So we talked about the risk of dehydration, but not specifically why. And a component of why is because of the decrease in that thirst mechanism. Which if you're going back to physiology, I don't think they'll ask you about, but it's related to a decrease in renal perfusion and sensitivity to ADH. All right, so we're going to move on to adapted and disabled athletes. Those are kind of like two separate talks in one that I am trying to pull all the high yield stuff in. So totally switching gears here. I wanted to start with some definitions because even this, if you're not intimately involved, it's kind of like a lot of times we lump these all together, but that's not true. Maybe with the Paralympics recently, people have been a little bit more aware, but an adaptive sport is a sport that has been adapted specifically for persons with a disability or created specifically for persons with a disability. So anyone can play an adaptive sport, like anyone can play wheelchair basketball. It was just adapted to allow people with a disability to participate on an equal level. Whereas the term parasport is something that's specifically played in the Olympic Games. So parasports are adaptive sports that are played at the Paralympic level. And then the Special Olympics is completely separate, and that is a nonprofit program that is for people with intellectual disability. So most people that play adaptive sport, they can have intellectual disability, but most of them do not. And Special Olympics is specifically developed for those with intellectual disabilities. And from a parasport classification, there are many things that impair your function that determine what group and classification you participate in. So again, if anyone watched the Paralympics recently and you watched like track and field, for example, there are multiple different categories for each race in which athletes compete. So someone who has bilateral transfemoral amputation is not competing in a 100-meter race against someone who has like a transhumeral amputation. Like those give you drastically different abilities to function. And so people who have the same impairments are technically competing against people with their same impairments. If that makes sense. So there are all these things. They're probably not going to ask you questions related to specifics of this. This again, I think is common sense from athletes that use wheelchairs for mobility versus prostheses for mobility, and those with wheelchairs are more likely to have upper body injuries because they use their arms for mobility. Those with amputations use prostheses for mobility and are more likely to have lower body injuries. I don't know why boards sometimes likes to ask those questions about like, is a wheelchair athlete more likely to have what type of injury? And again, common sense, like they use their arms to move their body. That's what's going to get injured. Autonomic dysreflexia, like if you're going to study one thing about adaptive athletes, study autonomic dysreflexia because you are probably going to get a question about it. So this occurs in athletes that have suffered a spinal cord injury that is at thoracic level 6 and above. And so a noxious stimulus below that level causes unregulated reflex sympathetic discharge. And that's because the sympathetic system that tampers down the system that tampers down your sympathetics is out with the injury above T6, and that causes hypertension, bradycardia, which results in patients saying they have a headache, blurred vision, sometimes just nasal congestion. They feel more anxious, peeler erection, flushing, sweating, and this only happens above the level of injury because below the level there, because of the injury, they're not functioning normally. The number one cause for this is a noxious stimulus. Therefore, the first treatment is to remove said noxious stimulus. They're going to ask you that question, or the hypertension bradycardia thing, or the level, or unregulated reflex sympathetic discharge. If removing the noxious stimulus from a treatment standpoint does not work, nitro paste and oral and IV nifedipine are the treatment. Nitro paste is typically the one that we most commonly use. I don't think they'll get into this question, but if you're ever in the scenario, if you're going to put nitro paste on someone, it needs to be above the level of their injury and you need to wear a glove. Otherwise, you're going to become hypotensive and that doesn't help the patient. We like nitro paste because you can put it on and when their blood pressure improves and their heart rate improves, you can wipe it off. And then the way that athletes use this to their advantage is through something called boosting, which is when they unintentionally induce autonomic dysreflexia, which is not allowed in competition. And they do this by many different reasons. If someone has an indwelling catheter, they can clamp their catheter. They can wear a really tight belt. They can pinch their skin to cause this noxious stimulus below the lesion. And it gives a competitive advantage for a while until you stroke, basically, which is why this is so scary. Other common conditions in our adaptive athletes, particularly in amputees, there's something called verrucous hyperplasia, which is also called choked stump syndrome, which looks like this. I'm not sure if on boards they're going to ask, but it would be to adjust and make the prosthesis bigger, proximal to this development. And then it's not uncommon to get some heterotopic ossification at the distal residual limb that can be surgically excised. And usually most of this, the answer to these things is modify the socket of their prosthesis. Other common conditions, orthostatic hypotension is very common, usually from venous pooling. And if you are ever in a scenario where you're in a Paralympic competition, IV fluids are prohibited by WADA in competition. So you would need a therapeutic use exemption for that. Obviously, if someone's life is on the line, you give it and then you do it retroactively, but just something to keep in mind. From a thermoregulation standpoint, because you have impaired autonomic function, you don't have the same ability to sweat below the level of injury. So these athletes are at higher risk of heat illness if in a warm environment, and because of their inability to feel, they're also at higher risk of like frostbite and things like that in a cold environment, because they can't tell that they're getting cold and then put on, you know, gloves or socks or whatever. Skin breakdown from pressure ulcers on insensate skin can be a problem. And then I had mentioned the verrucous hyperplasia, stump syndrome. Spasticity is something that you may also get asked about. I think the biggest, so spasticity itself is velocity dependent increase in muscle tone. So if you move someone's arm rapidly and the amount of tone increases versus if you move them slowly and it's less, that's called spasticity. It happens after an upper motor neuron injury. It can limit their participation in sport if they're not able to like rapidly move because their muscle tenses up. That's a problem for them to be able to participate, right? So then we treat it with medications, typically oral first, baclofen, dantrolene, tizanidine, benzodiazepines. I'm not sure they'll ask you those specifics, but I think all of those require a therapeutic use exemption. From an injectable standpoint, botulinum toxin and intrathecal baclofen, and then there are surgeries that can be done. You may get a question related to spasticity asking, and it's something like you have a spinal cord injured athlete who competes in sled hockey, and all of a sudden they have this like rapid increase in their amount of spasticity. What's the problem? And it probably is that they have some sort of systemic or otherwise asymptomatic condition. So if someone has a UTI, they get an increase in their spasticity. If someone has a fracture, they have an increase in their spasticity. So the biggest, like if you do get a question like that, the first thing is figure out if there's something systemic going on that needs to be fixed before you like would treat them for medications for the spasticity. Peripheral nerve injuries are really common in this population. So traumatic neuromas after amputation, compression neuropathies, particularly at the fibular, neck and transtibial amputations. And then carpal tunnel syndrome is extremely common in wheelchair athletes. And a question related to those would be something that you would know about those syndromes from another scenario, just in an adaptive athlete, and you treat them the same way. Like carpal tunnel, you treat the same way, whether they have a wheelchair or not. Maybe a little bit more conservatively if you want to avoid surgery. From an MSK standpoint, overuse injuries, just like in the general population, are common. Osteoporosis and osteopenia are significantly more common in athletes with spinal cord injury due to disuse. And the DEXA Z-score numbers here are listed for athletes. And fractures can happen and they might not report any pain if it's in an insensate area. So that's always, like, again, you could get a history. I think they probably ask this related to spasticity or to autonomic dysreflexia, where you have an athlete, they had like a minor crash of their wheelchair, their sled, and they like seem fine and they're okay. And then their blood pressure is really high and their heart rate's really low. And like you have to identify they have an autonomic dysreflexia, and the treatment is to try to figure out if something happened in that crash as step one while you control their blood pressure. From a concussion standpoint, this I'm just putting up here. They're probably not going to ask you anything about concussions, but just keep in mind a lot of athletes with disabilities, depending on their primary diagnosis, if they have a history of spina bifida, a lot of those athletes may have a VP shunt, they may have other head abnormalities. And when you're doing a concussion assessment, it's drastically different if someone has had a prior neurologic injury, one, because you need to know their baseline, and two, like if someone can't stand and do balance exercises, if they can't do like finger to nose, part of your neuro exam is really different. And there are specific guidelines that have been published. So again, if you're in this scenario, you can look that up. I don't think they'll ask you anything on boards beyond like what you can reason through from a standpoint of you need to know what their baseline like level is and adapt the concussion assessment for their impairments. So they have different ones based on vision, quadriplegia, and spina bifida. From an intellectual disability standpoint in Special Olympics athletes, this is characterized by intellectual functioning limitations and limitations in adaptive behavior. And they're the specific criteria for intellectual disability. I don't think they should ask you about that, but it has to happen before they're 18, and they'd have significant limitations in intellectual functioning and adaptive skill areas. The most commonly tested disabled athlete scenario you're going to get is probably related to Down syndrome. And they could ask any of these things, the cardiac abnormalities. They may ask something about a clearance standpoint, or what would you need to look out for. And endocardial cushion defect is probably the number one kind of buzzword, but they also can have ventricular septal defects, anterior septal defects, and then PDA as well, and pulmonary hypertension, and they have a lower heart rate at baseline. From a vision standpoint, cataracts, glaucoma, strabismus, macular disease, high refractive error are all common. And that, this is not a vision talk, but that needs to be corrected before they're able to participate in any ball related sports. And then ligamentous laxity, where anterior axial instability is probably the thing that you're going to get tested on, but you can see instability hips and patellofemoral dislocation as well. So this is relatively high yield. They're probably going to ask you something about this. So this is laxity at C1 and C2. It's actually present in up to 30% of people with Down syndrome. And typically, if they do have symptoms, they'll complain of neck pain, could see a cervical deformity, fatigability, abnormal gait, clumsiness, altered sensation, sensory defects, and then reflexes that are increased. Some people can be asymptomatic. If they have an X-ray, you will see the atlanto-dens interval greater than 4.5 millimeters. They love that number. And all kids are supposed to be screened between 3 and 5 years. And so for this atlanto-dens interval, what you do is take it X-ray in neutral and then an X-ray in flexion. And you do not want to see this instability where there's space here between the dens and the atlas of more than 4.5 millimeters. You want to screen in high-risk sports. You could get a question about the high-risk sports. Those are somewhat common sense, like anything that's going to involve a blow to a head. So if you're swimming or diving head first, doing the butterfly stroke, doing high jump or gymnastics or soccer or judo, snowboarding, alpine skiing, those things like all make sense, right, in terms of sports that are high risk. And someone created this probably without doctors in mind, but they're allowed to play if they have a signed note by 2 docs in any of these high risk sports. And I would never be signing one of those notes, but that's kind of the rules from the Special Olympics standpoint. But the high yield things here are 4.5 millimeters, and then these high risk sports. All right, questions. So I don't know who is Kevin's done 2 already, so Kevin Killian has done 2, so he's out for this one.
I think I'm up. You have volunteered to help cover the local Paralympics training facility in town. You heard that several players on the wheelchair basketball team have been clamping their urinary catheter to gain competitive advantage. What mechanism is giving them an advantage? I think we talked about sympathetic, unopposed sympathetic discharge. So that'll give me A or B. And I think there's increased blood pressure
Yep.
from post-sympathetic discharge. So I will go with A.
Correct. So if you're going to know one thing about adaptive sports, it's autonomic dysreflexia. And if you're going to know one thing about athletes with intellectual disabilities, it's atlantoaxial instability. Like those are probably going to be what they test. So for autonomic dysreflexia, again, just to hammer this home, history of spinal cord injury at T6, then you have this uncontrolled sympathetic response to discharge. Sorry, go back. And then you don't have descending control of the nervous system because of the lesion. You get headaches, flushing, very high blood pressure, bradycardia, which can lead to seizure, stroke, death. This is probably, I don't know the numbers, but the scariest like emergency in like adaptive sports and PM&R. because people can die quickly if you don't control it. And then the treatment is first identify the cause, and then the next thing is sit them up, loosen clothing, and like check bowel bladder, and then consider medications. So identify cause, sit them up and loosen their clothing, and like check things are like always the first thing that you do. Boosting is when athletes intentionally are trying to induce autonomic dysreflexia. Like I said, bladder distension, tourniquet, breaking their toe, like all of those things have been reported before. All right, now here's your, hopefully I hammered this one home enough for whoever's next. I get a,
4.5 millimeters.
there we go. Just remember that number. Don't even need to read the question. Which brings me to, again, like test taking things. This is a really long vignette, right? Do you need to know the vignette to answer the last sentence? No. So all of these questions, you should just read the last sentence and see what they're trying to get at, because what's really annoying is you read the whole thing and you're like, oh, this person has atlantoaxial instability, and then they tell you that. And then you're like, oh shoot, now what are they gonna ask me? Whereas if you read the last sentence of the question, you already either can just answer it from there, or you know what you're supposed to be like trying to look for as you go back and read the vignette, especially when they're long. Just like helpful test taking tips that can get you through exams. Yep, so lateral cervical spine x-rays, flexion to extension, atlantoaxial instability difference is 4.5 millimeters at the atlanto-dens interval. And anyone with myelopathic symptoms or signs needs to have this done. And then, like I said, you're recommended to screen everyone 3 to 5. And most people who have had a catastrophic spinal cord injury were then later found that they had atlantoaxial instability. So if we can identify this, it does help prevent things. And just here are those same x-rays that I talked about before. All right.
All right, yes, I'm up. Which of the following statements is true regarding the adaptive athlete when compared to their able-bodied counterparts? Wheelchair athletes are at a lower risk of fracture. Adaptive athletes are at a greater risk of physical, sexual, and emotional abuse. Wheelchair athletes have a lower risk of shoulder injuries. Entrapment neuropathies are uncommon in adaptive athletes. And adaptive skiers have a higher incidence of injuries than able-bodied skiers.
We didn't talk specifically about all of these, but you can.
Let's see. All right, so it's not. I would think it's not D. It's not C. I don't know if E's true or not. I feel like if you crash, you crash. What's better, A and B? Are wheelchair athletes at a low risk of fracture? I don't actually know.
They can't feel parts
I
of
mean,
them.
yeah, I guess yeah. So if they can't feel, they're probably at a higher risk.
Yep. Higher risk. So.
And adaptive athletes are at a greater risk of physical, sexual, and emotional abuse. I mean, if everything else is false, then maybe it's B, but
You're right.
okay.
So we didn't specifically talk about that one piece, right? But that was, you could rationalize your way and reason it down to at least it being one of two things. And unfortunately, it's been shown over and over that those who are more vulnerable are at higher risk of abuse. So that's commonly children, adaptive athletes, and women in general, and everything else, as you mentioned, was incorrect.
I think
Right.
this is me.
most-
The most
go ahead.
common nerve entrapment syndrome observed in wheelchair athletes is, I'm going to read the rest. I think we said carpal tunnel, but
Yeah.
I would also do second place D. I know we said around the fibular head can be common, but I'm going to go A, median neuropathy of the wrist.
Yeah. Yep, you're exactly right. And the common around the fibular head is in athletes with amputation, which they could also be a wheelchair athlete, right? Like you have an amputation, you don't have to use a prosthesis, you could use a wheelchair for mobility, but wheelchair, you're constantly using your hands to push. Carpal tunnel is by far the most common. So, good job. All right. another autonomic dysreflexia in case we haven't had enough of that.
Which of the following statements are true regarding AD? Spinal cord at or above T6 are unlikely. That's wrong. We know that's the level where it is likely. Athletes who have symptoms of AD rarely have elevated blood pressure. That's not accurate because that's what they get. Initial management should include head elevation identification. Identification, I do know, is the important thing. Let's see what the other ones are. Perpetuated by parasympathetic, so that's wrong. Tinnitus, sweating below. I feel like they don't sweat below. It's all above, so it has to be C.
Yep, correct. And the head elevation piece, again, if you think about things, right, if you sit them up, their blood pressure decreases going to their brain. It's the exact opposite of what you do with a hypotensive person, where you lay them down and they put their legs up so the blood flow goes there. And so that's why that is like, sit them up, find what's wrong, and then go from there. Does that make sense? You just think about it from a rational standpoint. So everything you said was correct. All right.
I think it's mine. For the individuals with limb loss / amputation, which the following statement is true. Participation in sports and recreational improves prosthetic use and function. Participants in sports and recreation improves quality of life. Can improve body image. I feel like a lot of this is true, so I'm gonna go with E.
Yeah.
All true.
Yeah, I don't think the board, this was in a board review book, but I don't think the actual boards are going to ask you with an all of the above answer option. But from an education standpoint, I feel like I wanted to include it just because it hit on some of the things we didn't really talk about. And basically, again, we're sports medicine docs, but the same thing we talked about with the masters athletes, like exercise is good. Sports are good for adaptive athletes in the same vein. So. All right, that is all I have. Do you guys have questions in general? No, yeah. Like just going back, like recap quickly from a master's athlete standpoint, if you know a lot of the physiology that happens with aging and can kind of reason through that, you're going to be good. From that standpoint with aging and with chronic disease, and then adaptive and disabled athletes like autonomic dysreflexia and atlantoaxial instability are probably going to get you like a decent number of things they're going to ask about. Like the boards asks about, seems like, unless they totally revamp it, they ask about certain things all the time. And some of the things that are high yield that you don't want to have that are going to like kill you, or they love physiology. So I don't like, just keep that in mind when you're studying. Like some of that's a little bit painful, but it seems like they always go back to a lot of that physiology and like, why are we a sports medicine doc type questions.
From a practical standpoint, for your pair athletes, like aside from like your Down syndrome patients and your like AD patients, like are there other like specific things from a pre-participation clearance standpoint that like you're supposed to do for them on a routine basis when you're screening them or clearing them, or is it all just dependent on like what their like condition is?
It's somewhat dependent on what their condition is. I'd say I probably, like for those, we should be very thorough. Most of them have pre-existing medical conditions and are on medications. The biggest thing to probably keep in mind, like in a real life scenario, is depending on the level of the athlete, if they're a high level Paralympic athlete, do they need therapeutic use exemptions for the medications that they're currently taking? And then sometimes on those, you're on their pre-participation physicals, you're more likely to find something that hasn't been worked up or known before, just because they're more likely to have problems. And so I think just being very thorough for those exams is important. But otherwise, you're doing a physical exam the same way that you would do a physical exam in an able-bodied person, just noting the impairments and things that they have. Good question. All right, if you guys don't have any other questions, then we can we can end this and can all get to clinic.
Sounds good. Thanks so much.
Yeah,
Thank
thank
you.
you very much.
See ya.